Hello everyone. The next developmental disturbances affecting oral and paraoral structure, that is dens invaginatus. Dens invaginatus is also known as dens indente and dilated composite odonto. So dens indente is a deep surface invagination of the crown or root that is lined by enamel. It is a developmental variation which is thought to arise as a result of an invagination in the surface of the tooth crown before calcification has occurred. So this is a gross picture of dens invaginatus, the dilated invagination with apical accumulation of dystrophic enamel. Then coming to the etiology of dens invaginatus, there are several etiology of this condition have been proposed, like there is an increased localized external pressure, focal growth retardation, focal growth stimulation in certain areas of the tooth bud. Then clinical features. The permanent maxillary lateral incisors are the teeth most frequently involved in dens invaginatus. And majority of cases, the dens indente appears to represent an accentuation in the development of the lingual pit. And sometimes the maxillary central incisors are also involved, and it frequently bilateral. So this is a picture of dens invaginatus type 2. There is involvement of maxillary lateral incisor exhibiting invagination of the surface enamel that extends slightly below the cemento-enamel junction. Here there is slight invagination of enamel that is below the cemento-enamel junction. There are two forms of dens indente or dens invaginatus, like coronal form and radicular form. Coronal form that affecting to the crown, radicular form that extending towards the root. By great margin, coronal dens invaginatus is seen more frequently as compared to the radicular dens invaginatus. When you compare the prevalence varies from 0.04% to 10% of all the patient. And the depth of the invagination that varies from a slight enlargement of the cingulum pit to a deep infolding that extends to the apex of the root. So this is a clinical picture of coronal dens invaginatus type 2. In the arrow mark, they are showing mandibular lateral incisor. There is a lingual bulbous enlargement at the site of coronal opening of enamel invagination, that is involving the mandibular lateral incisor. In the same patient on the right picture, that is a radiographical picture of mandibular lateral incisor. There is a radio-opaque and enamel lined invagination that extending below the level of the cemento-enamel junction. It is a clinical picture and radiographical picture of coronal dens invaginatus type 2. Historically, coronal dens indente has been classified into three major types: type 1, type 2 and type 3. In type 1, it exhibits an invagination that is confined to the crown. But type 2, the invagination extends below the cemento-enamel junction and ends in a blind sac that may or may not communicate with the adjacent dental pulp. And sometimes the large invaginations may become dilated, there is enlargement, and contain dystrophic enamel in the base of the dilatation. The third type, that is type 3, invagination extends through the root and perforates in the apical or lateral radicular area without any immediate communication with the pulp. In this type, the enamel that lines the invagination is often replaced by cementum close to the radicular perforation. And this perforation that provides direct communication from the oral cavity to the intraosseous periradicular tissues, and it often produces inflammatory lesions in the presence of a vital pulp. In the last slide, I have discussed that root invagination that causing the inflammatory response. In the clinical picture, you see there is a swelling, that is the parolis, overlying vital maxillary canine and lateral incisor. The canine contained of a dense invaginatus that perforated the mesial surface of its root. You can see in the radiographical picture also there is involvement of maxillary canine that exhibiting an enamel invagination that parallels the pulp canal and perforates the lateral root surface. So this is the classical example of coronal dense invagination type 3. Occasionally the invagination may be so large and resemble a tooth within a tooth. So the term known as dense indentate. In other cases, the invagination may be dilated and disturb the formation of the tooth, that resulting in anomalous tooth development, that is known as dilated odontome. And this involvement may be singular, multiple or bilateral. So this is a comparative picture of coronal dense invaginatus, that is type 1, type 2 and type 3. Type 1, that is the invagination, you can see the black color, which is confined to the crown itself. In type 2, it extends below the cemento-enamel junction, and in type 3, it extends through the root and perforates in the apical or lateral radicular areas. Then coming to radicular dense invaginatus, that is the involvement of root. It is rare and it is thought to arise secondary to a proliferation of Hartwig's epithelial root sheet with the formation of a strip of enamel that extends along the surface of the root. This pattern of enamel deposition is similar to that frequently seen in association with radicular enamel pearl. In enamel pearl, there is protrusion of the surface and there is altered enamel that forms a surface invagination into the dental papilla in case of dent in dente. And cementum line invagination of the root have been reported, but these represent a simple variation of root morphology and it should not be included under the term radicular dense invaginatus. So the radiographically the affected tooth shows an enlargement of the root, and close examination often reveals a dilated invagination that is lined by enamel with the opening of the invagination situated along the lateral aspect of the root. This is a clinical picture of a root invaginatus. Then treatment and prognosis of dense invaginatus. On eruption, the invagination of the affected tooth communicates with the oral cavity, and the soft tissue within the lumen undergoes necrosis, that providing an excellent environment for growth of bacteria. So in small type 1 invaginations that only limited to the crown, it should be restored upon eruption in an attempt to prevent carious involvement and subsequent pulpal inflammation. If the invagination is not detected quickly, pulpal necrosis frequently results. Okay, so with larger invaginations, the contents of the lumen and any carious dentine must be removed. Then a calcium hydroxide base may be placed to help to treat any possible microcommunication with the adjacent pulp. In case with obvious pulpal communication or any signs of pulpal pathosis, both the invagination and the adjacent pulp canal require endodontic therapy. In teeth with open apex, it should be apexification with calcium hydroxide is successful. If there is type 3 invaginations which is associated with periradicular inflammatory lesions, that type of invagination require endodontic-like therapy of the perforating invagination. Okay, and before final obturation with Gatapacha, temporary placement of calcium hydroxide helps to build dentinal bridges and maintain vitality of the adjacent pulp. If vitality is lost, endodontic therapy to the adjacent pulp canal is necessary. Some cases do not respond to conservative endodontic therapy and they require periapical surgery and retrofill. Large and extremely dilated invaginations often have abnormal crown and they need to be extracted. If the invagination doesn't significantly disrupt the tooth morphology, complications of radicular dense invaginators are rare unless the radicular opening is exposed to the oral cavity. After exposure occurs, carious involvement often leads to pulpal necrosis. An opening close to the anatomic neck of the tooth should be exposed and restored to minimize damage to the tooth and surrounding structure. So these are all about dense invaginators or dense indentae. I hope you like this video. Thank you so much.